Okay. What are the causes when they say somebody have thrombocytopenia? It's low platelet. So we have low platelet. But what can cause the low platelet? What can bring about low platelet? So it's distraction. Okay, we are distracting the platelet or less production. These are the two main ways of, I like bone marrow suppression is the same thing as less production, right? Hemolysis is distraction. I like that. Two main facts that will give you. And after that, you can find the causes. The pathophysiology is what is the two things over there. So these are the two main things. Then out of that, you can tell me the etiology. Now you can list a bunch of stuff. So what are the etiology of platelet distraction or production? Somebody say aplastic anemia, right? Bone marrow suppression. Bone marrow suppression it may be kind of chemotherapy related, right? Chemotherapy will lead to bone marrow suppression. Yes, chemotherapy. Somebody said, excellent. Bone marrow suppression. You guys doing good. What else do you think? Drugs, right? Drugs can do that. And somebody said heparin-induced thrombocytopenia. So we have heparin and we have some drugs too, right? Remember, you can have infection. Infection, the common infection is usually HIV and Hep C. Hep C are the most common cause of that. What else? I'll lead you guys so that we can keep going. Hematological malignancy, right? Like leukemia and lymphoma, those kind of things can do that. Those can lead to low platelet production or distraction. DIC, excellent. I like that. Okay. I like the spirit here today. DIC. This can lead to distraction of the platelets, decimated intravascular coagulation. What else? Anemia is a cause of it. Anemia doesn't cause the platelet problem. Anemia is something that is causing it. So that's not the issue. So you can have what? Idiopathic thrombocytopenia, ITP. Idiopathic thrombocytopenia. You can have thrombotic thrombocytopenia, TTP, right? And you can have heparin-induced thrombocytopenia. So these are the things that will cause that. Now, there's few things you have to know. Normal platelet count is greater than 150,000, right? Per micro, I would just put 150,000. Know these two numbers, right? Less than 50,000 and less than 20,000. Which of these will cause spontaneous bleeding? Which of this will cause spontaneous bleeding? 1, 2, 3. Which of this will cause spontaneous bleeding in a patient? And less than 50,000 is significant bleeding from trauma. So this will cause spontaneous bleeding. And this is significant bleeding from trauma. So we're setting the stage now. I like that. Right. Excellent. Okay. Now, since we know Now you got to know what the platelet, what is the function of it? What is the function of the platelet? What is the main thing it does? It forms a plaque. The platelet plaque is not coagulation. So coagulation is not anticoagulation. You see, that's why we don't call it anticoagulant. It does not, it's just involved in plugging. It plug things. Like you have a hole in your house or something, and something is leaking, you go and patch it. So that is what the platelet does in the beginning. Basically, form a clog and block the hole. Because of what it does, it can cause, it affect the your vessel, the blood from, basically it can lead to for them to be very thin and bleed for a long time, right? And it can destroy, if it's not working, you have bleeding, spontaneous bleeding everywhere. The reason why it's different, when you have platelet problem, you're not just bleeding just like that. There's certain features you see on the individual skin. So it's because of the way the platelet work. So what do you see when they have platelet dysfunction? What do you see? Clinical features. Yeah, they are not the same as hematoma. Okay, you see tiny, tiny pinpoint petechia. Those are platelet dysfunction, right? And you can see something we call purpura. It's not petechia, right? But it's a non-blanching. It's a non-blanching. What do you call it? Purple in color and patches. So they are not huge. They don't have a big, small patches, right? Easy bruising, right? You bruise this easily, but you don't have a big hematoma, right? What else? What other feature? I can help you. Mucosa, your mouth, you bleed easily when you brush your teeth. Okay, mucosal bleeding, that's key. And your nose just bleed like that spontaneously, right? Epistaxis. So those are the features of that. Okay, now we know the platelet function and everything that we need to know, right? These are the things. Now, there's few things you have to pay attention to. Bleeding after injection, excellent. I like that answer choice. So bleeding after injection. Well, that's a good one. Bleeding after injection. That's good. Or prolonged bleeding after injection. So the word prolonged has to be there. Prolonged in bleeding after injection. Your board will want you to know a few of them. There is ITP, okay, idiopathic. This is what? Idiopathic thrombocytopenia or immune thrombocytopenia, you can call it. So this is immune thrombocytopenia. It's different from TTP, okay? This is thrombotic, as you can see the name, thrombotic, thrombocytopenia, Purpura. You see, that is the name. And so those are the two things. Then we have something we call heparin-induced thrombocytopenia. And today I want you to know the difference, heparin-induced thrombocytopenia, and to be able to find the difference and be able to answer questions related to that. Right? Now, let's get to it on the go. Now that we set the board rolling. Okay. Now, so if you have a 35-year-old, okay, male, he has easy bruising. Okay, easy bruising everywhere, gum bleeding, right? Okay, that's the issue, right? And you check their platelet, is 70,000, right? I tell you, there's no fever. Patient does not have fever. There's no neurological problem. I'm teaching you how to do differential diagnosis. This is how the case will be. No neurological problem. Can you figure out just what I've told you? Can you picture it and see if it fall under this one of this? Giving you the buzzwords. I like buzzwords, right? Okay. No exposure to heparin. And it's the most uncommon cause of low platelet. And when you examine the patient, if I examine the patient, the spleen is small or normal. Look at their skin, they will have petechia, they will all the features of platelet problem, purpura, but the key word is the spleen is not destroying the vein. This is due to what? Them forming clot and aggregation. This is unusual platelet aggregation and chewing your platelets. It has nothing to do with the spleen. So the spleen is not going to get bigger, okay? They've not been exposed to heparin. Therefore, it cannot be heparin-induced thrombocytopenia. You see, there is heparin here. That's taking strategy. Therefore, I know this guy was not exposed, no exposure. Okay, I spelled it wrong. No exposure to heparin. And it's the most uncommon cause of low platelet. But it happened because the platelet form clot and it cause problem. This is what we call thrombotic thrombocytopenia purpura. They have neurological problem, they have no fever, they have fever, neurological problem, they have anemia, they have no exposure to heparin. It's the most uncommon cause of platelet, and this is what we have thrombocytopenia and thrombotic event. Now, if it's the same patient, and I change the scenario, and I say it's bigger than normal, spleen is big, I have some infection, usually viral infection, okay, and then they have no fever, no neurological symptoms, no exposure to heparin. And when you look at your skin, you have petechia, okay, they have gum bleed, they have easy bruising, or all the features related to low platelet. This scenario changes. Therefore, what do you think? This is classic ITP. The key word is spleen is enlarged. You have antibodies destroying your spleen. You destroying your platelets, and usually they occur in the spleen. Therefore, the spleen get bigger and bigger and bigger, and they become a problem for somebody who have ITP. What do you think, based on the pathophysiology? What do you think would be the treatment for that? So we treat the infection, but we got to do something else. Antiplatelets is not going to work because you have antibodies already. The antibodies will destroy your platelets. So we can't do that anymore. So you got to find other means to take care of it. So usually steroids will help. They get some steroid. And if the steroid, remember, whenever, this is the pathophysiology, whenever you have autoimmune disease, you don't have to think twice to pick an answer. Autoimmune, always go with steroids. Steroid will take care of it. If it doesn't, then they need surgery. So that is the treatment for ITP. Okay, don't forget that. Of course, you put the patient in neutropenic precaution after you do the surgery. After you do the surgery, this patient is at high risk of infection, and therefore you put them in neutropenic precaution because of the spleen is gone, so you have to worry about that. For TPP, for TTP, you do something we call plasmapheresis. Basically, you take their blood and then wash it out and then give it back to them. And that is what the treatment for in TTP, thrombotic thrombocytopenia purpura. You can mix the two. Yeah, splenectomy, remove the spleen. When I remove your spleen, okay, if I remove your spleen, I have to give you vaccination. This is number one. This is number one. Before the patient leaves the hospital, you got to give them vaccination because of encapsulated organism. This is what like Haemophilus influenza, pneumococcal. So they get pneumococcal vaccination. So H-flu, pneumococcal, and Haemophilus. Otherwise, they're going to sick. So these people are priority patient. They have to be in the private room as much as possible because they can get sick easily. Anybody who have their spleen removed, yeah, they can get sick very easily. There's something we call overwhelming post-splenectomy sepsis. I don't know if you've heard it before, overwhelming post-splenectomy sepsis. Because of this, we have to put this patient like neutropenic precaution as much as possible if they have a splenectomy, and they need to get vaccination for that. Now, this same patient, 35-year-old, okay, he broke his leg after a fall, started post-fall. In the emergency room, they did an ultrasound, and he has DVT. They put the patient on heparin drip. What are you going to do? What is your plan for this patient? I started on heparin drip. What are you going to do? If you are the nurse, what do you anticipate? How about that? Anticipate. Order to anticipate, right? Bleeding precaution, okay? Somebody said bleeding precaution. What else do you anticipate? Trying to trap you, people to fall for this. Which of these do you anticipate or indicated? Somebody said 1, 2, and 6. Somebody said 5. 5 is fine. I like that. So PT, you don't need a PT and this is Coumadin at this time. Lay down, right? NSAID is not good. But this is trappy. There's a knowledge here. Who think this patient will need Coumadin? Rabira said yes. So when you have DVT, we'll put you on heparin. Heparin drip, you can't go home with. You can't go home with that. So if you have to go home, you got to take something sub-Q or PO, right? So if we have to give you something sub-Q or PO, usually if you want to give you somebody to go home with something sub-Q, we'll start with enoxaparin right away. So enoxaparin to treat the DVT, which is lower molecular heparin. If we have to put you on heparin, there is the idea that we're going to transition. So this is a bridge. We'll transition you to Coumadin. When your PTT is therapeutic. So he may need Coumadin later on, but not right now. So you got to make sure he will need Coumadin. He can't go home with heparin drip. So after we give them heparin and we achieve a therapeutic range close to like 65, 65, 75, and we okay with that, we give them Coumadin while they still getting their heparin, and then slowly take away the heparin. So don't forget that. They will need Coumadin later on, but right now, it's fine. It's unless the PTT is therapeutic before they get the Coumadin. Day 1, heparin. So platelet, this is the platelet. It started with 200,000, right? Day 2 was 180,000. Day 4, 150. Are you worried? You should start worrying day 4 here. Day 5, 130,000. Are you worried? This is what we call heparin-induced thrombocytopenia. The diagnosis, this is the diagnosis. Heparin has decreased 50%. So it decreased 50% of its original, or it's less than or equal to 150. So this is a problem. This is what we call heparin-induced thrombocytopenia, induced thrombocytopenia. How does that happen? What do you guys think? Okay, you make antibodies against your own platelet. And what happens? You chew your platelet. So you make antibodies against your own platelet and you start chewing it. And due to the heparin, okay, heparin-induced thrombocytopenia, the exposure to the heparin, you make antibodies and you start chewing your platelet, you form platelet clamp. This is different from idiopathic thrombocytopenia. You are not actually destroying. I'm spending time to explain so that when you see a question, you are not destroying the platelet. What is the difference between HIT and ITP? I'm not destroying the platelet, but something is happening to the platelet. It's on the screen. I'm not destroying it, but something is happening to the platelet. The platelets are coming together. So they're more coming together. So they're coming together and they're forming clumps, right? They're coming together. What do you think is going to cause? What do you think is going to lead to? When all the platelets, a large amount of platelets is coming together, what does it lead to? They have a bleeding problem or clotting problem? Which one? If you have to choose one or two. It's a clot problem. Therefore, if you know it's a clot problem, the rest of your management, what should be your priority now? What is my priority? If clot is my problem, which of these is your priority? Stroke, hemorrhage, DVT, PE, MI, death. select or apply SATA question. So which one is more? If it's a clot, hey, you're going to have stroke. You're going to have DVT. You're going to have PE. You're going to have MI. They will have massive clot and they're going to die. Because of that, it's not acceptable. Holding heparin is not acceptable. And because it's hit, no more heparin. You should not give them any heparin. So your plan should be what? Stop heparin, enoxaparin, give them direct thrombin inhibitor, Coumadin. So if they give you this option like that, just be careful because you don't want them to die and have a PE. Remember, this patient had a DVT. So I cannot let them develop DVT anymore. If I hold the medication, then it does not have anything. He already going to have a clot burden. So I don't want him to get sick from the clot burden. I still have to treat him. So holding heparin is not a good option. So you should not hold it. Don't hold heparin. You need to stop it completely and never go near heparin again. You may have to change all your IV tubing. Most IV tubings are heparin impregnated. So you stop all of them. And enoxaparin is what? Is heparin, lower molecular weight heparin. So they should not get this. They should get, so this is wrong. They should get what? Direct thrombin inhibitor. This is another way your board will say it. That's why I'm using the word. I'm not giving you the drugs, but I'm using the word in case you see it somewhere. It's the same thing, direct thrombin inhibitor. Heparin is indirect. Remember, I told you about platelets trying to go to the injury site and form a plaque. This will lay down the scaffold. This is what we call foundation for clot formation. This is the mechanism. I didn't want to go into this detail, but this is the way it works, foundation. So what it does is heparin, when I give you heparin, it cannot go and bind to platelet directly. It asks for thrombin. It says, hey, I need you, thrombin, I need you. So it binds to thrombin, and both of them, heparin and thrombin, go and block platelets. And this does not happen. So heparin is indirect thrombin inhibitor, right? So that's the way it does its function. For this, we got to find direct medication that will go and block platelets directly or through the direct inhibitor of the thrombin associated with the platelet, right? So the direct one is, those are the Zabans. They have the last name as Zaban or Gatroban. You don't have to memorize it, but if you want, I'll give you one or two of them. One of them has last name Zaban, or the other one has a Gatroban. So you can have what we call agatroban. It's one of them. When you see it in the question form, or rivaroxaban. These are the two groups of medication that bind directly. And this is what they will need. They will never need Lovenox, or which is enoxaparin. You give them one of this, or you just give them Coumadin. So Coumadin will be able to take care of it. This is the management of heparin-induced thrombocytopenia. You should not hold the heparin. You should stop it, but don't stop from there. There's no need to wait. give them. So anticipate another medication, agatroban, rivaroxaban, because of the clot burden they're going to have. They will use the word paradoxical. Okay, that's the right word that you will see. Venous and arterial, whatever book they will use that. Venous and arterial thrombosis, basically. So that's why it's a problem. It's paradoxical. Even though you're chewing the platelet, it can lead to paradoxical venous and arterial thrombosis that can cause organ damage, stroke, PE. That's why it's dangerous. So that's the problem. So somebody said, what vaccine do we give to splenectomy patient? We give them, I told you, encapsulated organism. Don't memorize it. If you can know what organism have capsules on top of them, organisms that have capsules are cleared by the spleen. So the most common one, if you take your spleen, we cannot remove those organisms from your blood. You can get sick. Think about it. What are the seasonal vaccination we try to give to older people because their spleen doesn't work? Some people don't have spleen. What do you think? Just don't memorize that. I can show you how you know it, but you don't know them. Encapsulated organisms are common. It's one of those vaccines we have, right? I'll give you meningococcal, right? So those for meningitis. So those are one. Haemophilus pneumococcal, right? Right? Those are the ones we use. Then we give them pneumococcal, Haemophilus, H influenza. So H influenza, these are the three most common: pneumococcal, meningococcal, and H influenza. Some people also will get like streptococcal. So these are common encapsulated organisms that are deadly. They're really bad organisms. Any question? So we fixed this patient. If you develop heparin-induced thrombocytopenia, it's because you're going to have venous and arterial thrombosis. Because of that, stop the heparin. Don't hold it. Stop the heparin. Okay, assess the patient. Get some CBC to make sure they're not bleeding. Do a neurological exams to part of your assessment. Neuro exams, right? Stop all heparin impregnated tubing. You got to change them. And then expect direct thrombin inhibitor. You cannot just wait. Because of the clot bedding, they will develop massive thrombosis. Or you can give them Coumadin. This is your select or apply management intervention of heparin-induced thrombocytopenia. The patient went home, of course, you know what is coming. Coumadin. He went home with Coumadin. And then this is the teaching the nurse gives to the teaching. And if you can't figure out, well, he went home with probably, you have two answer choices. So if you went home with rivaroxaban, this is the teaching. Wait. Indicated. So question 1, and then question 2, and then I will leave. Find Vitamin K dependent factor, that is what Coumadin is binding to. But your test will trick you. You should not stop your vitamin K dependent, otherwise you're going to bleed or have thrombosis. You should not stop them. Consistent amount so that I can gauge what is going on. And you should not decrease either. So always when they give you Coumadin and they're talking about leafy vegetables, choose an answer choice that is consistent amount. And then these Zabans, you don't need any diet modification at all. And you don't need lab work. So daily lab work is gone. You don't need to check PTT, INR, no. Of course, you should avoid NSAID. You don't need to change your diet. So the right answer is number 5. Okay?